30 years, and I see all kinds of patients here, sports and spine. I do a lot of women's health, shoulders and knees, and pretty much anything except neuro. So I really love my job, and I'm really proud of OHSU, and I'm very grateful to be here today with all of you. So hopefully I can teach you a few new things, and looking forward to meeting many of you next year. Today we're going to talk about patellofemoral syndrome and iliotibial band syndrome. Running, as many of you know, is one of the most popular sports worldwide. It attracts hundreds of thousands of runners of all ages. 50% of regular runners report having more than one injury each year. Most of those injuries are caused by overuse. This just absolutely was shocking to me when I read it. The cost of total running-related injuries is estimated to be $4 billion annually. So hopefully from the lecture, you'll be able to spot some things that you might see in your patients that might help them prevent an injury or help them rehab that injury early on. You'll see in some of my notes, patellofemoral syndrome, abbreviated as PFPS, and iliotibial band, ITB. So I didn't want that to be confusing to any of you. Today, we'll talk about common complaints that you might see in patients. We'll talk about treatment, returning to running, and hopefully we'll have time for a case study today, and for sure time for questions. So patellofemoral syndrome is also called runner's knee. A patient will typically come in and complain of pain around the knee or under the kneecap. It's a very diffuse pain, insidious onset, and often associated with an increased activity. Kind of a nagging pain. Every once in a while, they'll complain of a sharp twinge, but for the most part, it's a generalized pain that's not specific under the kneecap or around the knee. And if you see runners, it's often going to be if they have a race coming up and they have just picked up the pace or the mileage a little bit. This, where the man's hands are, is kind of a description what patients will do when they come in to see us. They'll say, my pain is just kind of right here or under the patella. The risk factors for patellofemoral syndrome are female more than male. They have a decreased quad flexibility. You might see a hyper flexible patella, decreased quad strength, and someone who usually specializes in just one sport. Again, patients will complain of activities that put load through the knee. Oftentimes patients will say, if I sit for prolonged periods of time, if I go up or down the stairs, or if I do squats, I get that pain that I can't quite put my finger on. There's a lot of compressive forces on the patella, as you can imagine. Walking has half your body weight, jogging three to 4 times your body weight, and sitting to standing 6 to 7 times your body weight. Other causes of knee pain, if you get somebody with an anterior knee pain that you're evaluating in the clinic, I won't go through each of these today, but these are things that you want to be thinking about in the back of your mind as you're diagnosing what could be wrong with the patient. The diagnostic indicators of patellofemoral syndrome are you've ruled out other more serious conditions of the anterior knee. The patient complains of pain with any kind of resisted knee extension, whether that just be a quad set or you resisting the quad knee extension. They might have pain with posterior medial or posterior lateral pain, like the man was showing with his hands. And most patients complain of pain with squatting. With the diagnosis, we want to see kind of a cluster. We want to see at least a couple of these symptoms to rule in patellofemoral. We often also see a weakness of the posterior lateral hip musculature, specifically the abductors, which help prevent that knee valgus during loading. The iliotibial band is a little bit different. It's the most common cause of lateral knee pain in running. You'll see a patients will come in and complain of a loading when the knee is in a flexed position, usually about 30 degrees, when they're squatting, running, or going downstairs. Patients complain of a particular sharp pain, and they can usually put their finger right on it. A lot of patients will say, I can run a certain distance, but after that certain distance, I feel a very sharp pain in my lateral knee, and that prevents them from continuing to run. So as you're taking your history and getting to know your patient, if someone is describing these things, going downstairs or pain with running, oh, sorry, I thought Connie was talking to me. You'll want to start to think in your mind, I wonder if this could be iliotibial band syndrome. Again, I see a lot of runners in our clinic that say this. Typically, if a marathon is coming up or they have a race coming up and they've increased that mileage, the increase in volume, as well as if they've started adding hills, specifically downhill, you will see IT band syndrome increasing.
ภาพของเศรษฐกิจขณะที่กรรมการ2 คนเห็นควรให้คงอัตราดอกเบี้ยนโยบายโดยเห็นว่า
Please, everybody mute.
2.5 ยังสอดคล้องกับแนวโน้มเศรษฐกิจและเงินเฟ้อและให้น้ำหนักกับการรักษาเสถียรภาพ
Hello, please mute.
การรักษาขีดความสามารถของนโยบายการเงินในการรองรับความไม่แน่นอนในระยะข้างหน้า
So keep going, Connie.
Yeah, keep going. Yeah, sorry about that, Molly.
Not a problem, not a problem at all. The function of the IT band or the iliotibial band is to give us a lot of anterior and lateral stability. It helps stabilize the knee during walking, running, hopping, and it also provides the patellofemoral stability. The attachments, there's so many attachments to this big, strong band. It helps, it's what gives us stability when we're walking, running, and things like that. We see it attached to the patella, the patellar tendon, Gerdy's tubercle, the fibula, the lateral femoral epicondyle. We also see it attaching to those big, strong muscles that we need for lateral stability. The gluteus maximus, the tensor fasciae lata, and 3/4 of the gluteus maximus, a tendon actually attaches to that. We also see it attached to the gluteus medius, the biceps femoris, and the vastus lateralis muscles. So this is a muscle that is very well connected, which is one of the reasons it's nice and strong. This is just a few pictures that I grabbed off Hutchinson article to show the various attachments and exactly where it is and attaches at the lateral knee. When patients come in, they kind of complain of pain right just above the patella. One of the things that's important to know, when I was first a physical therapist, when we were treating IT band, we learned that you want to stretch it. You want to do a lot of soft tissue mobilization. You want to do foam rolling, anything you can do to get that IT band longer. And now, many years later, we learned that it takes 2,000 pounds of force to increase the length of the IT band by 1%. So we no longer try to stretch the IT band, and we realize that it's important that we don't stretch it. And we're lucky that we can't stretch it because it provides, again, a lot of stability for that knee that we need. It can often be, when we massage it or stretch it, it can be irritated. I won't say that I never have somebody do some foam rolling on there to kind of break up maybe the pain cycle if it feels good to the patient. But I know that when I'm doing it, I'm not doing it to lengthen the tissue. So what causes IT band syndrome? Again, when I was first a physical therapist, I learned that it was a friction between the IT band and the lateral femoral epicondyle. And they believe that there was a bursa in there that the IT band was kind of rubbing over. But research has shown over the years that distal into the IT band is very, very stable and it doesn't move. They also tried to find this bursa that was there and they couldn't find one. So that theory was quickly dismissed. And now they're thinking that it's likely due to compression on the fat pad between the IT band. So when the knee bends and straightens, we get some compression on that fat pad, and we now believe that that is what's causing that pain. What about shockwave therapy? I don't know actually a lot about shockwave therapy, but I can certainly look into that for you. We do not use it at OHSU, but I will look into it and see if I can find any research for you. Thank you for that question. Again, with iliotibial band syndrome, patients will complain of pain going down the stairs, running, squatting, in positions where the pain is in about 30 degrees. Sometimes when you get a patient that's really, really irritated, they'll even complain of that sharp pain with walking, but that's just if they've pretty much ignored their symptoms and kept irritating it. With running, patients complain again of a sharp pain at the lateral knee, a tightness that continues as they continue to run, and pain often during that early stance phase and when they're going downhill. When they're starting to train, they'll complain of pain with increased speed, increased fatigue, and maybe if they're going trails. If they're going trails, typically we're running with a more narrow base. So a lot of times if I hear a patient saying, oh my gosh, I've been doing more trail running lately and my lateral knee is killing me, and it involves some hill, the first thing I'm thinking of is that iliotibial band. Fatigue is strongly linked to the IT band during running, because as we get more tired, we develop more of a knee valgus position. Other causes of lateral knee pain, again, in your mind, anytime you get lateral knee pain, even if in their history they're describing some of the things that I've talked about, you still want to think of other causes that might be contributing. One is the patellofemoral, can refer to the lateral knee. Sometimes that we can get a lateral collateral sprain that they can complain of in that area, but it's more associated with trauma. Somebody with the lateral meniscus might complain of pain with the lateral knee, but typically that's more with a twisting motion rather than just a bending of the knee motion. Arthritis in general can give you pain to the lateral knee. A biceps femoris tendinopathy, but patients again would feel it when the knee is just more extended than in that flex 30 degrees position. You might suspect a hamstring strain. Again, typically when I see someone with a hamstring strain, they're complaining of pain more up in the muscle belly area. Somebody that complains of any kind of nerve injury would also complain of tingling and numbness. Typically, IT band patients do not complain of this. Or I'm always with my runners watching out for a stress injury, especially if the patient is very young, thin, and they complain of pain with a lot of weight bearing. I am going to be watching out for that. Typically, that is a sharp pain, however. The lumbar spine, as you all know, can also refer to the lateral knee. So in my mind, I'm keeping that in the back of my mind as I'm taking the evaluation of the patient. Back in the day, we used to believe that the Ober test was the test to help rule in IT band. Numerous research projects have now shown that the Ober test does not test IT band tightness. The Noble, sorry, I'm just getting over this cold, so I'm going to put this cough drop in. Any questions so far I can answer? Okay. The Noble test is the test that we use. You'll see her doing this on the left-hand side, where we're flexing the knee to 30 degrees and palpating around the lateral knee. You can do it in a squatting position. You can do it in a sitting position. You can do it sideline, supine, whatever position you have the patient in. You're just palpating that lateral femoral epicondyle as you move the patient through flexion and extension around 30 degrees. Yeah. When we're screening for both IT band and patellofemoral, when we're screening for both IT band and patellofemoral, there's lots of things that we're thinking of. Like I said, the other causes of anterior knee pain or lateral knee pain are things that we're going to look at. We're also going to look at patellar mobility, the Noble test, like I just said. We're going to be palpating that medial and lateral knee and see if that brings on pain to indicate more of a patellofemoral syndrome. I'm always going to screen the range of motion of the hip, the knee, and the ankle. We're going to look at strength, flexion, and extension. Remember that the quadriceps during loading helps stabilize the knee during that early stance phase. And that is when the iliotibial band is most irritated. So if the quadricep muscle is very weak, you're going to see more demand put on that iliotibial band, which might cause more knee pain. Really big on looking at hip abduction, extension, and external rotation. As runners, I'm a runner myself, so I'm guilty. As a runner, we're very trained in this plane, and we're not so trained in the lateral plane. So we really want to start strengthening those lateral stabilizers if they happen to be weak. Not everybody is weak, of course. Ankle dorsiflexion and plantar flexion, there's not actually a lot in the literature that talks about the ankle and how, and weakness and how it relates to patellofemoral syndrome or iliotibial band syndrome. But as a runner, we know that those muscles are very important. I don't talk a lot about that in this lecture, but I always train it with my patients. We also want to look at strength. We'll talk more about how you test strength with these patients who are typically pretty strong in the normal to good strength range. We use repetitions to fatigue, and at OHSU, we use dynamometers, and I'll show you some pictures of those. I'm always looking at the balance of the patient. How do they do in single leg stance? Do they have good stability, or do they have some foot weakness or poor hip and knee control? I'm really looking at that. I'm looking at motor control or movement coordination. How's the quality of their movement? Yes, maybe they can do a single leg sit to stand, but how well do they do it? How well do they control the motion? I might look at them running in place or hopping. And of course, I'm always going to do gait analysis to help see if I can figure out pieces of the puzzle. Crepitus is a question I get asked several times a day, as I'm guessing that you might also. It's a common concern of patients where they complain of a grinding or a popping or a cracking. And they always want to know, am I hurting myself moving through that? The research clearly indicates that although crepitus is common, it does not indicate that exercise is damaging or harmful, and it's okay to work through. So as I said, we use dynamometers for patients that have normal to good strength. So if somebody comes in and they're pretty darn strong, I want to know how strong they are. So guessing that many of you are familiar with this if you've been to OHSU, but if you're not, it's a device that we can put on the patient. It's right here. It's right here in this picture. I don't know if you can see. Can you see where I'm pointing, Connie?
Yes.
Thank you. Right here, or you can put it in the front of the shin. We actually have the patient strapped down to this table, and we have them kick with as much force as we can, and that gives us a reading. And we do this 3 times in a row and take the average of the 3. If we're testing the glute, we're going to have the knee bent in a prone position if the patient can tolerate it, and where Aki has the dynamometer put, we're going to test it there. Hamstring or hip extension with the legs straight, and then of course hip abduction, which is really important to test. We're going to have this leg slightly abducted and extended to test that muscle. This is a really amazing tool that we probably started using in the last year and a half. Again, even though there's not a lot of literature done, I always want to see how the patient is moving. If you look at this, you'll see his left side moves pretty high, and this one doesn't move as high. So not only am I saying If the patient could do it, I would have them do a single leg heel lift. But I'm looking at, okay, what is the quality of the movement? Maybe they can do 10 single leg, which is normal, but maybe the quality isn't good, or maybe the height isn't the same. Maybe the speed is less on one side. I want to make sure I'm documenting that. So can you do one leg? You'll see her doing 2 legs for the soleus. And then she does one. Oh, she did one. Good. And then can you do one leg? She never did one leg. Sorry, I think the video got cut up there. But I'm going to look at the gastroc and the soleus just to kind of see in generally what they're doing. And if I see a deficit, I'm definitely going to be training those muscles along with the others.
Molly, is
Yeah.
there any way to test without a dynamometer?
Yeah, I mean, you can do standard muscle testing like we've always done in physical therapy. Another thing you can do is repetitions to fatigue. I use that quite a bit before we started using these. So if somebody, I might see how many times can they do a certain motion, sit to stand, single leg sit to stand, heel lifts before they become fatigued. And that is a great way to document strength. Maybe in the beginning they can do 1 or 2 without pain. And then maybe as they progress through rehab, they might be able to do 10, 12, 15. Great question, Connie. When we're looking at gait analysis, the things that we want to look at are, and I'll show you some videos in a minute of people running. We want to look at, do they have excessive hip adduction? Do they have contralateral trunk lean? Do they have contralateral pelvic drop? Do they run with a narrow base? Like I said, some of the times when the runners start running on the trails, we get a lot of people coming in because they get irritation when they have to stay on those narrow trails. Do they get a varus stress on the knee? Are they overstriding and landing on an extended knee? Or do they have increased internal rotation during stance, or very common, a decreased hip extension? So we'll look at some videos together so you can see. This runner that you're going to see, she's a pretty darn good runner. All 3 of these runners actually are very, very good runners. They're Boston Marathon runners. They're New York Marathon runners. They all have different styles. So just because somebody comes in and is complaining of pain, if somebody's running and they're not complaining of pain, I don't usually mess with their running style, especially if they're a competitive runner. I might give them a few tips here and there, but if they're coming in and complaining of pain, that's when I'll start to give them little subtle things that they can do to help continue to run and decrease their pain. Okay, good job. Are you holding on? Try not to hold on. She keeps her pelvis nice and right there. Okay, good. In a second, I'm going to have her cross her arms. The quality of this isn't good right now. I don't know why. In a second, I'm going to have her cross her arms. If you look at her, she keeps her feet pretty even. She doesn't cross over at her level. Her hips are pretty level. She's got darn good hip extension. She doesn't excessively over rotate or move her upper body. In a second, I'm going to have her cross her arms. When we have somebody cross their arms or go a little bit faster, the deficits really show up. Okay, now see if you can cross your arms in front of you. Okay, then just regular. Unfortunately, is that fuzzy for you guys? Are you holding on, trying to?
Yes,
Okay, good job. Sorry about that. It hasn't been fuzzy.
just in parts, but then it goes clear.
Okay, so this runner is, again, Boston Marathon runner in the United States. That means they're a very good runner. They have to qualify to get into that race. She's got a very different running style. So you'll see her knees are very close together. She lands on her foot with a lot of pronation, a lot of adduction of that leg. She's bringing her leg in. She doesn't have nearly as much stability. She's got pretty good hip extension for her. If she came in with knee pain, I would bet she would come in with lateral knee pain because of how close she comes in together. Let's hope this one's a little better. You can see how she lands in pronation and kind of crawls in.
A little bit faster if you can.
Dang it, I don't know why this isn't working. In a second, I think she'll cross her arms. You can see there she's got her arms crossed and she's really starting to cross, kind of come across the center line. Her knees are coming closer together. So sorry, these videos are not. Okay, this guy has a very narrow base of support. So if you watch him run, his feet are going to be super close together and he rotates his body a lot. If you evaluated him in the clinic before you watched him run, you would see, if you know what a positive Thomas test is, you would see a positive Thomas test, which is indicating the length of his tensor fasciae lata and also how much hip extension. He would not have very much of a hip extension when I checked him in the clinic because of his running style. So watch how close his feet are together and watch when he has to cross his arms. Watch how he kind of, it isn't super obvious, but he has to do a little bit more lateral bending of his trunk to get his leg through. Oops, wait, oops, we gotta go back. Okay, there he is. So super close together. You can see him cross over there. So when he lands, there he's crossing his arms. So you're going to see, well, unfortunately, is that pretty fuzzy for you guys too?
It goes fuzzy and then it goes straight. But when they watch it on their own, when you send it to me, I think it'll be fine.
Okay, sorry about that.
No, that's
Anyway,
okay. Can I ask a question really quick?
absolutely.
Is BIM on
Vim,
call? This is at BDMS. BIM.
Yes,
Okay.
yes, Ronnie.
Do you want to give anybody, do you have to give them notice about turning their cameras on or anything today?
Yes,
Do you want to do that right now?
yeah, sure.
Okay.
Sure, I will tell
Do
them
it
right
in
now.
Thai.
Okay.
You can do it out loud.
โอเคค่ะทุกคนที่เข้ามาในเว็บ X นะคะก็รบกวนให้ปิดไมค์แล้วก็ปิดเสียงนะคะตอนก่อนจะเข้ามานะคะเพราะว่าเสียงมันจะรบกวนทางตอนคอนเฟอเรนซ์อยู่นะคะขอบคุณค่ะโอเคConnie I already told all the participants
Excellent. Thanks so much, Bim. Tan
My
let me know
pleasure.
that you were the leader today.
Good.
yes, it would be fun to see some faces out there.
Yeah, I would love them all to turn their camera on so we'd see their face, right?
Exactly. Okay, functional tests that I do in the clinic all day long, which is going to help me determine the treatment progression, the discharge, my rehab success. I want to start seeing changes pretty quickly as I'm treating a patient. And if I'm not, then I'm starting to ask myself, what's going on? Am I on the right track? Is something, do I need to start paying attention to something that I'm not? I'm going to listen to what the patient says as far as subjective outcome measures. How long can they run before they have an onset of pain? How many stairs can they go up and down before they have pain? Can they do a single leg sit to stand test? And not only can they do it, but what is the quality of their movement? I'm also going to look at a lateral step down test. And here is a example of a lateral step down test. It's not just can the patient touch the floor, but it is what is the quality as the patient moves down into that lateral step down. When I'm doing this with patients in the beginning, sometimes they have a hard time moving a long way. So I might shorten up the step height and I'm going to measure how much flexion they have of the knee. So as the patient progresses, I can say, in the beginning, you were only able to do this flexing at this much of your knee, and now you really can move much more through that range of motion without pain. So the more information, as you all know, the more information we give our patients, the more positive feedback we give them, the more we show them how much they've come, how far they've come. Even if they have continued pain, they like that. They feel better. They feel more encouraged and inspired to keep doing their exercises. So with this test, we're looking at, can they keep their hands on their hips? Can they keep alignment? Does the knee come in? We're looking at the speed of movement. So as you're testing your patients, write down as many things as you can so that when the patient changes, you can say, well, look how far you've come, not just a lateral step down, but you're moving through that range of motion with improved coordination, improved speed, more control. How the patient moves is extremely important. In the literature, they talk a lot about using the visual analog scale. We don't use that a lot at OHSU, but I think it is an excellent test. You may use it in Thailand, where you take a line from and have 0 to 10, and you have the patient mark down the worst pain and the usual pain. And you measure from the left-hand side of the line to where they mark, and then you show their progress with that. Again, this is used a lot in the literature. And I think even if you're not using that scale, asking your patient, what's your worst pain and what's your usual pain? So we don't just want one mark in time. We want to say, hey, your pain is getting a little bit better. You can also use the anterior knee pain scale. At OHSU, we use the lower extremity functional scale for our knee patients. The great thing is, as you're treating these patients, is that patients usually get better and are able to return to running, especially if you catch it early. So that's always good to know. Quad and hip strength are generally the underlying tissue problem with both patellofemoral and IT band syndromes. So those are things we're going to want to be laser sharp on, is where are they weak in this problem so that we can help them get better. Some patients get irritation in the iliotibial band. Other patients get pain in the patellofemoral joint when you have weakness of those muscle groups. So you're just kind of watching out. The treatment is very, very similar for these patients. And I'm going to take you through how I usually treat these patients. Any patient that I'm seeing, I'm looking, no matter what the literature says, I'm looking at what is this specific patient's problem? What do they want to be able to do, and how am I going to get them there? So really focusing on, if you were on my other lecture, what is important to the patient is going to help you go a long way. And as I mentioned before, runners, we train this way and we don't train a lot laterally. We like to get her done. We like to get out there, run, and get it done. But it's super important. We can go faster with more stability, less injury if we train those strong hip muscles. The current recommendations for patellofemoral syndrome, even though this is from 2019, it is looked at every year, and there have been no changes since 2019. They look at they develop the guidelines on how we should treat these patients by looking at over 4,500 scientific articles. And they look at the risk factors, diagnosis, the examination, outcome measures, and they tell us, here's what we recommend that you do. And we obviously follow recommendations on how to treat the patient. Again, we're always looking at how is this patient uniquely different, but we are following research guidelines. So the conclusion from the study and the review was the best treatment is a combined program of both hip and knee strengthening. So we want to combine those two, specifically those two muscle groups. The combined strengthening exercises were better for reducing pain and helping people return to their normal activities than if you just strengthen the knee only. So usually early on, I'm going to start strengthening that hip if the knee is really irritated, to give them more lateral stability. The knee exercises can be weight bearing or non-weight bearing. We want to get them loaded and weight bearing as soon as we can, but sometimes people come in, they're pretty irritated. And so we can't always start them where we want to. The hip exercises are important. And again, I usually start those really early on because patients can tolerate those. We want to slowly increase the frequency, intensity, and duration of activities that load the knee. Treatment techniques in the literature which have very low evidence for being effective. Dry needling, manual therapy. And with manual therapy, they're saying if all you're doing is manual therapy and you're not following it up with exercise, the evidence is very low for both patellofemoral and IT band syndrome that this is going to be helpful to get the patient back to their normal function. Patellar taping with the aim of enhancing muscle function. I definitely will show you in a minute that I use taping, but only initially in the early phases of treatment and only in conjunction with exercise. We do not recommend, or excuse me, the literature does not recommend bracing. They do not find it to be effective. Now, if I showed this to a friend of mine the other day when she was asking me something about her knee, she was like, bracing helped me, it helped me so much. And I'm not saying that these little tiny things are not going to help the one-off patient, but they're not really documented in the literature, shown to help be the most effective way to help our patients. Biofeedback for quadricep exercise is not recommended or low evidence for helping patients. Again, there's going to be patients that you might use this every now and then, but it's not shown in the literature to be effective. Biofeedback, agents like ultrasound, ionophoresis, electrical stimulation, or laser. I've got to remember to find out about shock therapy or shock something that somebody asked me about. Questions?
I
What
thought I would
about
ask
the
because I like to remind
yeah?
people. Oh, sorry,
What
Dr.
what
VK.
yeah? What about the knee support with the open patella? Do you use it a lot? A lot of running use it, but I ask them to stop it certain time.
Say that again.
You can. How about the knee support with the open patella? Do you recommend?
No, we don't. Research does not recommend using bracing, right? We want to teach the patient to use, in the beginning, again, every patient is different. If you're looking at what the research shows has evidence, bracing, and I would consider a sleeve to be bracing, there is low evidence. Okay, so would I recommend that my patient use that? Probably not. Would I, in a minute, you'll hear me talk about taping and some other things, and foot orthotic. I would recommend those because the literature backs those practices up. Any other questions? We'll have plenty of time for questions, I think. Okay, so in early management, our goal is to kind of calm things down, to get that irritation. And it depends if we're seeing somebody really quickly after they've injured themselves, or if it's a long time and they've really let that tissue get irritated on where we're going to start. But our goal in the beginning is treat the pain and addresses the cause of the pain. So ice is often helpful for swelling. I use taping. Research documents taping is great for the knee in the first 4 weeks to help with pain management, as long as it is associated for the purpose of pain and combined with exercise. We also use orthotics, off-the-shelf orthotics. In America, they cost about $60. We used to recommend custom. Now we find that off-the-shelf are very, very helpful. We recommend in the first 6 weeks, and the research recommends in the first 6 weeks, to help control that pronation that we saw in the video where the person was really falling into pronation and increasing the lateral knee pain. Bracing, again, is low evidence in the research. Stretching, again, stretching is not in the research a lot, but if I'm doing a range of motion test with my patient and I say and I see, for instance, that the rectus femoris is very tight, I'm going to stretch that. I'm going to have them stretch that. Even though they don't talk about it a lot in the research, I do know that that's going to keep them from extending their hip. And then patellar mobilization, if I find it's hypomobile, I'm going to work on that.
We have 2 questions in the chat.
Okay?
One is, apart from hip and knee exercises, should we do calf exercises?
I do calf exercises, so this is me talking instead of the research. I always like to present to you all what the research is showing. Yes, you should do calf exercises. You should strengthen the gastroc and the soleus, so strengthening with the knee straight and the knee bent. And eventually doing that with single leg, because they're landing on a single leg. As far as these 2 diagnoses, there's not a lot of research in the literature about foot strength and how it impacts these 2. So I did not include a lot to present to you, but with my own running patients, yes, I can't describe orthotic. With my own running patients, I do use, I do include, if they're weak, I'm going to include strengthening of the foot and ankle. Wherever I see the patient weak, I'm going to work on strength. If their trunk is weak, I'm going to work on strengthening their trunk because we need a lot of trunk support too.
Good
But
answer.
if you look at the literature, it's talking primarily about the hip and the knee. I mean, the quads and the hips. But just like with any patient coming in the door, you're going to look at that whole patient and you're going to say, what is this patient? How is this patient unique? How can I help this individual reach their goals? And it might include some things that that are not in the literature. Somebody asked, could I
Oh,
explain?
wait, don't go there.
Okay, sorry.
In case of a running event, they need to join the race. So they usually wear knee support. Is that okay to wear it only for the race?
I mean, I think you have to decide that with your patient. I can't think of a reason I would say no. They're wanting to race. If the knee support helps their knee in the race and they really want to run the race and it helps them feel better, if you were my patient, I would probably say wear the brace. But that is not in the research. And in the research, they say, I think what they're talking about in the research is don't brace people, keep these people in braces, take away their muscular control by having the brace help them. I believe that's what they're saying.
Yes.
But we all, if you treat runners, you know what? You're going to, if we get to my case study, which, well, maybe we won't, but in my case study, I had this patient who wasn't getting better and I was like, wow, she's doing everything. And I run at 5 o'clock in the morning and I run hills. And what do you know? Even though she told me she wasn't running, one day when I was out running, there she was running. And so we don't always know why our patients aren't. They might tell you they're not running, but you know that runners run. So you can keep that one in the back of your mind. Okay.
And can you describe the orthotic you would recommend?
Absolutely. Superfeet are off-the-shelf orthotics. They make lots of different colors. We tend to use green. It's basically cut out the shape of a shoe and you take out the insert of your shoe and you put this support piece inside the shoe. And you can move it from shoe to shoe if you run in more than one running shoe. And it helps prevent pronation so that we can get the quads and the hips stronger without irritation. But we want to take that orthotic off and help get that foot strong. Usually, a lot of times with my runners, once I get the hips strong, the foot settles down. The foot has more control. But without that hip or knee control, it really falls into pronation. Any other questions on that one?
Do you know, like you've named a name in the United States, but
I don't, but you know what? I can look, I'll do a little research. I'll see
okay.
if I can
How
find
about a knee strap?
you again, a knee strap is a brace. It's not something in the literature that is taping. You can use a piece. Do you do kinesio taping or anything like that over there?
They
Taping-
do.
Okay,
They
there you go.
kinesio-taped my ankle when I heard it.
Yay, there you go. So taping is a great option. Taping is a great option if the tape helps relieve the pain, which is why we're using it. You could use taping. Taping is a great thing to use.
Great.
Okay, so taping, I got to remember all these things I said I would find out about. Connie, if you could help remind me.
Yeah, thank you.
Okay, so sometimes in the beginning, if they just push through it and they have all these pain, we want to load the joint as quickly as we can, but we want to stop activities that are increasing their pain so we can get them back to where they're going. So we may, in the beginning, if they're just like, oh my gosh, I'm doing laundry, or I can't even do my activities of daily living and kneeling and all these other things, I'm going to take them, I'm going to say, try to stop doing those for just a short while so we can really calm that tissue down. I would recommend cross training in the pool. You can try the stationary bike, but a lot of people continue to have pain in that lateral knee or patellofemoral with the pain. If they are having pain on the bike and they're just set on riding a bike, try to raise the seat of the bike up, and sometimes they can do a little bit, but the best place that I have found with my runners is in the pool. You don't want to push through the pain. You want to find the right amount of pain to create, you want to find the right amount of stress or loading to create change without pushing through it. One of the biggest questions you'll get asked is, can I continue to run? And what I say is, you can continue to run as long as the pain is 0 to 3, it settles quickly, and it returns to baseline within 24 hours.
And Molly, just so you know, they have the best aquatic therapy programs.
Wow, they are lucky. So you can refer them over to the aquatic therapy people, or if you're doing that, you can do some exercise for the quad and the hip in the pool. That'd be great. In the beginning, I say try to run flat and level, stay off the trails, and it's better to decrease the distance when it's irritated than irritate it and try to catch up. So here's some exercises that I do early in the treatment. Shoot, I thought this might be a video, but it's not. Okay. So a lot of times, if we're even activating the quad early in intervention and you have them do a quad set, they will complain of a lot of pain in the knee. So I like to take a big rolled up towel, as big as it needs to be, and have them do some quad sets with the rolled up towel, pushing into that knee. And a lot of times that's very well tolerated, and the patient gets confidence by doing that. Like I said earlier, bike with the seat elevated. We might be able to do a straight leg raise if they can tolerate that. Really working on the hip early, oftentimes in a non-weight bearing position, either with clamshells or with bridging, super helpful. I'm big on the trunk. I find a lot of my runners are weak in their trunks, so I start with side plank. And early on, if I can, to help with the hip and the trunk, getting their trunk stable so they're not doing a lot of side to side movements or rotary movements and throwing themselves off balance. As soon as we can load the joint, I get them loaded. So I might start with weight bearing in the weight bearing position. Oopsies. Oh, sorry about that. I might start them with an isometric contraction, just holding. If they're having a lot of knee pain in that position, I can put them in a high wall sit. And in the beginning, we want to start them with a posterior knee position with the knee behind the foot. That's the least irritating. And we can see, have them hold this position for a while, 20 to 30 second hold, and start to strengthen that quadricep. As soon as I can, I'm going to have them doing some squat to a surface. I like to have them squat to a surface. I think it's great training for sitting to standing. We can also measure the height of the surface and help the patient see when they're progressing. So maybe I'll start with a really high surface and show them that they're doing a squat, which they get very excited when they see they're doing a squat. And I might add a weight if they can do that. I might lower the surface. And as soon as I can, I'm going to get them doing single leg activities to get those rotators of the hip involved early on. Let's see here.
People that have been at OHSU would know that was Sarah.
Yes, that is Sarah. You can do, I start step ups pretty darn quickly. Lateral step downs, like the picture I showed you before. As they get stronger, I'll check the angle of the knee and I'll show them again positive feedback. Oh, look how far much further you're moving without pain. As that is no longer painful, I'm going to work into increasing the range of motion into a lunge. We want to work that posterior chain to get them nice and strong there. So I might do some deadlifts, and initially, if they're having decreased balance, I'll have them put their finger on the wall. Then I'll have them try it without the wall. And then gradually we want them doing a little bit of weight. For bridging, again, glute max. Now this is irritating for some patients, excuse me, who remember we talked about earlier that the glute max attaches into that IT band. So people have a really irritated iliotibial band. Sometimes strengthening the glute max will become irritating. So watch your individual patient, and if it's good, I would definitely do this exercise. Double leg bridge, going to single leg bridge, and then off the table for a little bit more glute activation. I'm big on the trunk, so I'm going to start with a side on the knee and the shoulder. In this position, her shoulder is a little bit further out than I would like. I'd like it right underneath her. If she can, I'm going to have her legs straight. And let's see if I can get her. Shoot, this is a video that isn't showing. Oh, well. Good. Oh, she might do it on this side. Okay, so
You can see it, yeah.
he's
But
going
you
to
got
pick up
this
on this side.
funny when you see the dot here thing over top of it.
Me?
Yeah.
You see the dot?
It says when you see the dot here, you'll know that people are chatting in the meeting message.
I was hoping she would lift this up.
So we can't really see her move.
Okay, did you, on this one, you could see her move though, right?
Just a little bit, but this message is right on top of her.
Okay, sorry. This one, hopefully, when you,
Anyone else have more questions?
Yes. Oh, Dr. Wanapa, did you ask if anybody else had a question? Or do you have a question? Dr. Wanapa?
recommendations for running downhill. I would not recommend running downhill when they're in an irritated phase. I would gradually bring them back to running. So start flat, start level, and then train distance first or volume first, and then start to train hills or speed. And in the beginning, I would start, kind of train where they run flat, and then they run a hill, and then they run flat, and then they run a hill. So hills are kind of coming and going, and not just go out and run a hill over time. As they get stronger, that'll be a lot easier for them to navigate. Thank you for that question. So exercise progression, we want to go from isometric to double leg to single leg, and then we want to add weight. We don't want to change too many things at the same time. I am notorious for that. I'm going, oh, they're getting so much better. I'm going to add these things in. And every time I do, I have to slap my hand because I know better than doing that. But I just want my patients to get better. So I think, oh, try this. Symptoms usually improve as strength improves. Again, the progression rules are we want to pain 0 to 3, pain decreases quickly after exercise and returns to baseline within 24 hours. Our goal is to increase tolerance to different stressors over time. If the patient gets more pain or swelling, they're the main indicators that we are moving too quickly. And I really am watching. I want the patient to be improving in some way each week. For balance, static balance, let's see if I can get this one to show. When you're watching this, because you'll get a copy of this, you'll see I'm having you can't see it in the video for some reason. Oh, this one, let's see if he does it. Nope, sorry about that. Okay, well, in the video, he's standing on one leg and he's moving his arms as if he is running. And he does a really good job of maintaining control. He keeps his pelvis level, he keeps his knee in good alignment, his foot is nice and stable, and those are the kinds of things that I'm looking at with runners in balance. Hello. Shoot, none of these are going to be, oh, good. So you can see Sarah, she's running in slow motion, although she's not really. And
Molly, there's a question.
yes,
I have certain numbers of patients with poor ankle control and they are runners. How or what is your recommendation on progressive strength training if ankles specifically?
that could be a whole lecture all in itself, but I will tell you that you're going to want to do, again, just like you're doing here, decreasing the stress on the ankle. So if they can tolerate it, I will have them do double leg heel lifts. If they can't tolerate that, I might have them use a TheraBand. I'm going to train the soleus. I'm going to train the gastroc. I'm also going to look at the everters, which are super important. I'm going to look at the big toe stability for runners, if I'm looking specifically at the foot. If they can do the TheraBand, but they can't really do weight bearing, I'm going to have them lean over a table and do some heel lifts. That's very helpful. So I can take some of the weight off, but not all of the weight, kind of in a plank position. I wanted to have them sitting in the beginning, just kind of sitting, lifting their heels for the soleus, gradually adding weight, gradually increasing, maybe even adding from an incline.
Okay, and the next one is running should start from incline to flat surface, decline as knee angles start from slightly bend to full knee extension. Is that right?
No, we typically have our patients running flat and level. So in the very beginning, while the irritation, we have them running on flat level surfaces. So they want to make sure they're not running a trail or a street that's kind of tilted. We want it flat. If they can, even on a soft track in the very beginning. As their irritation goes down, we can add some hills, either up or down. But in the beginning, we want to start flat, and then we want to start adding that back in as the irritation goes down.
Perfect. In case of a shin splint, what is your recommendation for exercise?
I think what we should do, and I'm happy to answer all of these questions, but to get through this, I think we should keep going on this, and I can write all the questions down, and then at the end, I can answer that. Are you okay with that?
Yeah, we have, how much more do you have?
I have 20 slides. And
Whoa.
and
Well, they're going to be able to review them because you'll send them to me to send to them. What do you think is important to share right now?
I think what is important, this is just showing jumping, impact is important. These are different jumping. Now these videos are working. Can you see those people moving?
The Sarah moving, but not the guy.
Oh,
Who's the guy?
There he goes.
Oh, there he goes. Who
Right.
is that?
But he's going to stop. Brendan, he's pretty new.
Okay.
Okay. Okay, treat, test, was it effective? Return to running. I like my patients to be able to walk for 30 minutes, mostly pain-free, with their activities of daily living, and that they could run in place for 1 minute. If they can do that, then I'm going to try to take them through a return to running test. This one is out of Stanford University. We have them walk for 30 minutes. Again, before I even did this test, they would be able to do that. Can they do a single leg heel raise 25 times? Can they do a step up? Can they jump double leg for 60 seconds at a pace of 180 beats per minute, which I'm going to check that. I'm going to put on a metronome so they have to do it. Hopping and a single leg squat. I'm looking for quality of movement, quantity, and symptoms during the test. When our patients start running, we're going to have them do a walk-run progression. And we're going to really make them try to stick to that because we found that that's super effective. After they get to the 10 minutes of jogging, they can increase 10% per week. Another thing that's very common is gait retraining, like the patients that I showed you that were running on the treadmill, I might put a mirror in front of them and say, hey, I want you to try to land more in the front of your foot. I want you to land a little bit softer. I want you to try to keep your feet just a little bit more apart. Oftentimes, if we increase their cadence, if the cadence is too low, by increasing the cadence, we're going to put less stress on the knee, which is going to help that knee pain. So decreasing stride length, decreasing width, and decreasing hip adduction is all going to put less stress on the IT band. If there's a mirror, we're telling him, take up just a little bit more room on the treadmill, shorten your stride, and increase your pace. Again, I use a mirror a lot. I'll start with the mirror, and then I'll take the mirror away. I'll give them a lot of verbal and visual feedback, and then I'll take it away. I might put a line down the middle of the treadmill. I might try to distract a patient while after they get good to see, okay, can they do it even with distraction? Decrease running downhill, decrease trail running, and decreasing on uneven surfaces. So we've talked about signs and symptoms and early management for pain management. We've talked about the importance of hip and quad strength. We've talked about gradual loading, and we've also talked about gait retraining, looking at the pelvic drop. How close are the feet together? What is their cadence in helping them return to running? Oh, this next one I want to show you. Okay, so a 30-year-old case study. We can always skip this so that I can answer your questions. But this is, I hope to goodness gracious that this one works. Because I want you to all put in the chat, how old is this guy? Okay, here he comes. Ready? Please tell me it's going to work.
There it goes.
This guy runs. For some reason, it is not running. Okay, 30 years old. Okay, keep going. I want to see everybody put in.
Somebody said 65, 68.
Keep going. There's a lot of people on here. I want to know how old is he? Dang it.
54,
Are we ready? Keep going.
70, 68, 30, 80.
I like that guess. 45. Good job, you guys. Thank you for guessing. Makes this much more fun. Okay. Drum roll. 87 years old. This guy's got,
Oh,
if I would have had him on the treadmill, he would have one of the most amazing gait patterns you've ever seen. So again, this is a lifelong sport. People can run at any age. It's so amazing for health and cardiovascular health. It is, if you have a runner, it's great. Oftentimes patients use it for their mental health. So I'm really careful about how much I hold them back. If they can run, I want them to at least run a little bit because, like I said, it's for mental health. At least a lot of people in the United States use running. So as a way to calm anxiety. Okay, any other questions?
yep. Can you answer this?
I don't
Yes.
actually see a lot of shin splints, but in the beginning, again, that's an overuse injury. We see that a lot during the beginning of track season. For the high schoolers, we see a lot of people coming in with shin splints. So ice, decrease activity, and some strengthening, especially of the anterior tibialis. But I can get you more information on that.
Can you write his name down or her name down?
Whose name?
It's THAVATCHAI. I got it down.
Okay.
So that we can get more information. That would be great.
You bet.
But it looks like people are dropping off, going to work.
Well, thank you so much for coming, and
you.
I hope that you'll think about your running patients and all the ways that you can help them. And I'm really looking forward to meeting all of you. And thank you so much for coming today.
And Dr. Wanapa,
Yes. Yes.
Oh. do you want to finalize it for us?
I just want to say a few words only that thank you very much once again for the learning opportunity and the knowledge gained a lot from Molly and Connie in the back. as
you.
always. Okay, we look forward to receiving the slide and then we can have it, seeking your permission to upload for other people who cannot listen to this morning lecture. Thank you.
Absolutely. Thank you so much.